Yeah, the major adverse events of bispecific antibodies are infections, but there's a proportion of patients who develop cytokine release syndrome, particularly after the first administration. So you have to be careful, and that is the reason why in the package insert it is still recommended that you should admit patients just to watch them, and if there's other signs for CRS, then you start with corticosteroids, and you may also use tocilizumab in order to mitigate these side effects. You can also use tocilizumab preemptive before you start with the administration of bispecific antibodies, and then you reduce the risk for CRS. It is very rare that patients develop ICANS. So immune effector cell neurotoxicity adverse events, and these are usually grade 1 or 2 and of short duration. The most important consequences of this treatment with bispecific antibodies is, of course, the higher infection rate. Actually, the infection rate with these drugs is higher than with any other drug which is used in myeloma. But we are on the beginning of a learning curve. So when you look at some studies, you see an infection rate of 45%, in other studies of 80%. But you have to, when you analyze and read these reports, you have to consider that the follow-up time of different studies differs significantly. So some studies have a short follow-up time of 4 to 5 months, and in the Majestic 1 trial, which used teclistamab, you have a large follow-up time of 18 months. So you have automatically a higher infection risk when you follow your patients longer. And we also have suggested to change our reporting of infections, particularly in patients who are treated with bispecific antibodies, because the recommendation is to treat those patients for longer periods, even if they are in complete remission. And in the old days and presently, we just capture 1 infection per patient, and that this is recorded. But a patient may experience 2, 3, 4, 5, 6 or more infections during a 2-year treatment period. And if you want to compare the infection risk between different studies, you have to standardize the reporting of infections. And our recommendation, I think that is published in Blood Advances, is that you report the infection rate per patient normalized per month, and that you record each individual infection, type of infection, and grade of infection. This gives you a better view of what is really going on, and you can compare the risk between different bispecific antibodies. But I should also mention that the risk is higher with BCMA targeting BiTEs. Why? Because BCMA is expressed on B cells, on normal plasma cells, and when you eradicate B cells and plasma cells, your IgG production goes down, and you have very almost always then immune globulin deficiency. You have low IgG values below 400, and if this is encountered, you should use prophylactic IVIG substitution in those patients to mitigate the risk for infections. And this has been shown that this is an effective strategy. But if a patient comes in with repeated infection, you should also consider antibiotic prophylaxis. I think other prophylactic measures, I think it's clear that we use prophylaxis against herpes viruses. Against pneumocystis, I don't think it's really needed in all patients. There may be selected patients with specific risk and severe neutropenia for a long time, where you may consider Bactrim in those patients, prophylaxis with Bactrim, prophylaxis against PGP infection. What I strongly feel is that we will now improve our management, and in the future, infections will not be such a major threat to our patients because our management will improve, our prophylactic measures will improve, and the incidence of infections and the grade of infections will go down, and we will handle those complications in a much more efficient way, as we did at the beginning when we started to use bispecific antibodies.